I've virtually carved this presentation based upon my own experience, and it is full of anecdotes, so please do pardon me if it is over the top. Minimal invasive surgery or a gunshot wound. Now, the agenda is, as I said, I'm not going to bore you guys with data. I'm going to give you some definitions, hard facts, and what do patients require. Why do I think, yes, minimal invasive surgery in some aspects of knee replacements or shoulder surgery could be compared to a gunshot wound. And we'll look at what can be good about MIS and what can be quite an ugly issue. So what is surgery? What is an operation? The treatment of injuries or disorders of the body by incision or manipulation, especially with instruments. Fairly simple. What is invasive? It is a procedure is that one which penetrates or breaks the skin or enters a body cavity. What is minimally invasive? The Mayo Clinic says it is to operate with less injury to the body than with open operation. So the rest of the presentation is with emphasis on knee and shoulder surgery, which is what I do. Minimal invasive surgery, I think it crept its head up probably about 2004, 2005, which was when I was appointed as a consultant. This is certainly considered as an evolution in the field, and every medical advance should be embraced somewhat with caution if need be. Smaller surgery, smaller incisions are fairly cosmetically appealing. There is a lot of public demand. It's like the Daily Mirror phenomenon. Somebody says, oh, I had this fantastic big operation with a very, very small little hole in my knee or shoulder, if you like, and yes, I got better. And suddenly you'll get influx of patients who say, oh, I want that. I want a minimal invasive surgery without really knowing the intricacies of it. What does it do? It helps you to rehabilitate quickly. You could go home sooner. There is, again, with due respect to the industry, of course we need them, but there are instruments that can be manufactured to perhaps make this particular job slightly easier, and there is an industry push to urge the surgeons to say, look, do this. There are some marketing individuals like the Mr. Shiny Gonzalez, who's a speedy surgeon who wants basically a lot of business and he wants to get patients out the door quicker. So minimal invasive surgery, the intention, as we saw, is to reduce the damage or respect the soft tissues. It is a fantastic operation for arthroscopies, for keyhole operation, endoscopic type of work, ligament reconstruction, cartilage transplantation. We do all of that, and I do it, shoulder surgery as well. In doing these procedures, we do truly respect soft tissues. It is impossible, if I was to say, to do a cartilage trimming operation open as compared to arthroscopic. Now, the other side, the flip side of the coin, is with reference to joint replacement surgery. Now, is it possible with osteoarthritis to do joint replacement surgery with minimal invasive approach? I've got my own doubts. Why do arthroscopic procedures work? As we said, the arthroscopy or the endoscopy or the camera improves the visibility of the soft tissues or the part that we need to really see. It consistently reduces rehabilitation time, improves recovery. Patients can go home slightly sooner, and evidence is there in the literature to say that MIS surgery can be quite good. But does it work in osteoarthritic pathology? What is osteoarthritis? It's basically a roughened up joint, and as somebody used to say, knees go first and teeth later. Every one of us, I'm sure there's nobody sitting here who's over 60, but everybody who reaches maybe about 50 or 60 will need a knee replacement surgery by the looks of things. It's possibly because we are more active than what we used to be. Certainly surgery is required when all conservative line of management fails. So pain management, physiotherapy, injections, if nothing is working, and if your quality of life is suffering, patients will need some operative intervention, and knee replacement is kind of the end stage procedure. What do patients want? Patients want pain relief. They want to go back to their previous mobility. They want the quality of life back, and preferably low complication rates. Majority of the time, they don't come looking for a minimal invasive approach unless the Daily Mirror has printed an article the previous couple of weeks. So literature would say that minimal invasive surgery leads to faster recovery. Yes, it does, but is associated with frequent delayed wound healing, possibly complications. There are no differences as far as rehabilitation is concerned if you were to compare the initial rehabilitation as compared to the post-operative, intermediate or long-term outcomes as such. Patients don't care what you use as far as tools to do your operations, whether you use navigation, whether you use a shiny prosthesis, the color of the prosthesis. What they want is to return to the mobility. They want to get rid of the pain and go back to their activities of daily living. They just want value for money. And soft tissues, I think, are a very, very important factor in doing so. Minimal invasive surgery, so as far as knee replacement is concerned, the picture on your left, that's a small incision through which a knee replacement can be done. And the blue line is the traditional knee replacement approach. So there's quite a sizable difference, and the outcome can be seen on the picture on the right side. And again, the patient had a minimal invasive surgery on the right side and a relatively normal procedure on the left side about 2 years later, because the outcome of the minimal invasive surgery was not that great. Now, with replacement to joint replacement work, I'm not talking about arthroscopic, but joint replacement work, it's like peeping Tom type of approach. You look at, or you wish to look at, the tissues through a very, very small hole. Can you see it all? I don't know. The accuracy can be impaired. This approach can be done, so you can have a minimal invasive approach, but you do need to use navigation. Navigation is virtually like our car navigation. These prongs that are sticking out of the bones are a approach of the computer telling us exactly what we're doing and where we're cutting the bone if the cuts are required. Because if you have a very small incision, this computer will kind of guide you to say, yes, you're doing the right thing, and stop, you're doing the wrong thing, which it is very difficult if you don't have that type of approach. Minimal invasive surgery is quite glamorous, small incision. If you were to look at the ruler type of approach, 6 inches, 4 inches, 3 inches, those type of thing. So the picture shows the old incision. This is of the lady who had the first procedure done through an open approach, and the new one through a minimal invasive approach, or the other way around. So what about soft tissue bruising? Quite a lot of it, because though the skin is cut to a very minimal amount, because that's basically what one can see, on the deeper side there is quite a lot of soft tissue injury. The picture on your extreme left, this is a lady who's had 2 knee replacements done at the same time. One surgeon doing the minimal invasive approach on one side and the other one doing the traditional approach on the other side. Look at the soft tissue bruising. It's a fairly simple thing to note. So why do we call this as a gunshot wound? Yes, of course, if you were to look at the gunshot, it looks like a very deceptively small wound. Virtually big enough to stick your index finger into it. But then when you go to explore the wound to check the damage that that bullet has done, it is significant. And if you were to look at it through x-rays, it's completely shattered the bone. So what I'm trying to say is minimal invasive surgery for a particular type of operation may not be the best thing, because it does not respect soft tissues. Are all patients suitable for it? There might be a few patients that are suitable, but not all, and it's fairly multifactorial. It's quite good to have lean patients with knees that don't have extra material around it, but I think these days it is very difficult to get those type of patients. And what we have in that particular picture, it shows is BMI over 45, over 50, fairly common. Usually in a 15 new patient clinic that I have, we'll have about 5 patients who will be over body mass index of about 40. And that is fairly common. This was a knee replacement that I assisted when I was a fellow in the States, and Yeah, it is scary, isn't it? It is absolutely scary. Complexity. Not all knee osteoarthritic deformities are suitable for it. There are some straightforward ones that you may get away with it, but again, majority of the time, if knee replacements are delayed, then it can be quite difficult to do these type of knee replacements through a very, very small incision. Deformities. Again, if you leave osteoarthritic knees for a long time, then they become what is called as a complex primary procedure. So even through a big incision, you'd be struggling. So through a small incision, there's very little chance. Multiple scars. If some patients have had previous operations, there's a lot of scarring, and this done or dealt with through minimal invasive approach may not promise good results. So what can go wrong? Complications of knee replacement through minimal invasive surgery, and this is all to do with soft tissue damage. Poor visibility will cause soft tissue injury, fractures. If we can't see the bones well enough, sores, orthopaedics is sophisticated carpentry. So we do cut bones, and if we can't see what we're cutting, it can be quite difficult. Patellar tendon ruptures. I've got an anaesthetist whose father-in-law was having a knee replacement surgery, fairly straightforward operation, ended up with patellar tendon injury, which was a complete tear of the patellar tendon. That patient will never normally walk again. So it's a straightforward approach, but things can go wrong. Malalignment. It's again carpentry, so you have to cut the bones and you have to align the prosthesis so that the long axis of the prosthesis is fitting with the long axis of the bone. Can we get it right through a very, very small incision? Infections. Again, you don't respect soft tissues, you'll get something like this, and that's not desirable after a knee replacement. So once you get rid of the infection and when you're closing the skin, that's how scary it looks. The soft tissue envelope is all that remains, and then the bone and metal. Amputation is one of the last resorts if infections were not to come under control. So malalignment, if you were to see the picture on your left, the first on the left side is a properly aligned knee, whereas the other one is not. And again, the picture on your extreme right is an unstable knee. It's virtually dislocated, if you like. Instability, the kneecap not being in place, and there is a frank dislocation of the knee. These things do happen in clinical practice. Skin necrosis, bilateral minimal invasive surgery. How scary can it get? Of course, it can be salvaged, but look at the outcome of this type of knee replacement surgery. Venous issues. This is something that we do get time and time again. It is very difficult to manage them, and again, it's a problem that when we get patients with venous ulcers or lymphedema or chronic cellulitic legs, we do refer them to the vascular surgeons, and the very standard answer we get is, oh, there's nothing wrong with the veins, get on with it and you'll be fine. It is quite difficult, and I have had a few infections with knee replacements, and all of them are due to or with patients who've got cellulitic legs. It is a difficult situation as far as knee replacement is concerned, because these patients, if they do have osteoarthritic legs, they do need knee replacement surgery. And I think a combined approach, which certainly is helped through networking, is the right thing to do. So knees can be a significant challenge to treat. Quality assurance wise, what is anybody doing about it? Outcomes. As far as surgeons are concerned, we're very, very happy. We're doing a very good job. We do pat ourselves in the back, but our patients saying the same. There is a disparity. And how do we address it? So in 2009, the Department of Health started a program called PROMS program. PROMS is Patient Reported Outcome Measure. It's not what the surgeon says. It's not how happy he is. It is with reference to how happy the patients are. And if you were to see this graph, this is a funnel plot. The red line in the middle is kind of giving you a all England average, if you like. So if you were to have figures above that particular line, then you're fine. All these dots are surgeons stroke hospitals. So these are combination of their knee replacement surgery, and the outcome is based upon what the patient says. It does not take into account what the surgeon says. So if you were above that red line, then you're doing fine. If you were above that dotted line, then you're doing significantly fine. That's about 95% confidence interval, whereas the solid line is 98% confidence interval. Now look at the flip side. If you go under the red line, and if you were below that line, your chief executive comes down and says, "Doctor, instead of doing knee replacement surgery, do you want to do foot surgery?" And this is happening. This is happening because in today's day and age, where patients are so internet savvy, there's a thing called "do it right the first time." So there is quite a lot of bearing on it, and these type of data and scatter plots will be available on the internet per surgeon, per hospital. So we, through our pedantic approach, and it's a team approach, it's not a one-man band at all, it's a team approach, we analysed our results, and this comprises of about 600 odd knee replacements, and our results are roughly about that. And that basically is with reference to Oxford score. Oxford scores are scores of how bad your patients are, and after you do a knee replacement surgery, how better they can get to. And there's another parameter which is called EQ5D, which is a general health measure. Again, our results are around there. There's no point in giving a fantastic functional outcome if these knees are falling apart. So we do what is called survivorship analysis, i.e. Look at how many knees have been done and how many are surviving, i.e. they have not been revised. So we've revised one knee in about 10 years. So what does produce these results? Of course, you have to have patient selection. You have to select them properly. If they're not suitable for a procedure, alternatives can be adopted. Patients do need good peri, pre, as well as post-operative care. That's absolutely important. Rehabilitation, and of course, we have to paint realistic pictures. Physiotherapy is very, very important. If a knee replacement is done and if the physios are not involved, or if your patient doesn't want to do physiotherapy, that's bad result. Soft tissues, respect them with care. During our unit knee replacement surgery, retractors are instruments that are really banned. We use them only if we need to use them. Unrequired dissection is absolutely not allowed. Skin incision can be as large as possible, and I think skin is a very friendly soft tissue. You cut it sharp and it'll heal up quite nicely. Skin heals from side to side. It does not heal from end to end, but the tissues underneath are fairly precarious. A vital lesson when I was finishing up my training was to treat bones like hard tissues and soft tissues like women. This is what my old boss used to say. Bones are fairly happy to be hammered. They're like men. They will complain, but they'll shut up and keep quiet. Sorry, men, but soft tissues are like women. You treat them with TLC and they'll reciprocate quite nicely. But if you don't, I don't need to say any more. Thank you very much.